Hello students. Today we will discuss about mouth preparation for complete denture patients. Mouth preparation includes all the measures taken to correct tissue discrepancies that pose a difficulty in the placement of a denture. It means to say that we prepare the mouth or oral cavity of the patient as to to correct the tissues or any abnormalities present in the oral cavity, so there will be no difficulty in placing the final complete denture in the patient's mouth. This is one of the procedure in which we prepare the oral cavity, like certain removal of the tori, excessive bone or tissue to place the denture. Mouth rehabilitation is defined as a restoration of the form and function of the masticatory apparatus to as nearly normal as possible. So, in short form, we can say that mouth preparation is similar to the mouth rehabilitation, in which we make it normal as much as possible for insertion of the complete denture. Adjunctive care, ulcer, lesion, and abscess, etc., require immediate attention. The lesion should be cured and the tissue should be given adequate rest for sufficient healing. During the healing period, adjunctive therapies like tissue massage, use of mouthwashes, etc., should be carried out. It has to say that if patient is suffering from ulcer, lesion, and abscess in the oral cavity, the immediate care should be taken of it, and the tissue massage and mouthwashes should be done, and sufficient healing time should be given before doing the complete denture procedure. For patients with normal tissues, 40-hour rest 40-hour rest with frequent tissue massage is sufficient. The patient should be advised to stop wearing the existing dentures. So next is tissue conditioning materials can be used to reline the existing dentures to reduce tissue inflammation and thus facilitate in subsequent surgical procedures. So they said if there is any inflammation due to denture or something, then the tissue conditioning materials can be used, which will be easily reduce the inflammation. Removal of retained dentition, like after the extraction of teeth, certain teeth are left in the mouths, like root stumps or the uh, grossly decayed teeth or the educate teeth. The decision to remove or preserve the tooth is planned during the treatment planning, so an OPG gives a clear idea about the status of remaining dentition. Now, removal of unerupted tooth and removal of retained roots. Removal of unerupted tooth involves the line close to the ridge should be removed. Deeply smudged, non-symptomatic with normal bony tubercle can be left untouched. Removal of retained tooth. All retained roots should be removed, especially retained roots are also known as root stumps. Removed especially if there is any sign of pathology or any abnormality or pain. Asymptomatic roots which are present deep in the bone, whose removal can result in large bony defect, can be cautiously left untouched. Now, the correction of hypermobile ridge tissue. Hypermobile tissue results due to excessive residual ridge resorption. Like there is a sudden increase in the ridge resorption which may lead to formation of the hypermobile tissues. Now, the small areas of hypermobile tissue which may not affect the functioning of the denture can be left untouched or should not be done anything with it. These mobile tissues should be recorded carefully using a mucostatic impression technique. In mucostatic impression technique, we use a material which can easily flow. Large pendulous hypermobile tissue should be removed. Like if there is excessive ridge resorption and there is excessive hypermobile tissue on the ridge, then it should be surely removed, as it may hinder the impression. Removal of soft, it will also, the hypermobile tissue also reduces the retention and stability of the denture. Now, removal of soft tissue interferences. Firm soft tissue interferences which do not affect the stability of denture can left intact, And in case of maxillary tuberosity with excessive fibrous tissue, the need for surgical removal is evaluated by the articulating the diagnostic cast. Now, removal of hypertrophic maxillary frenum. If the frenal attachment is high but not close to the crust of ridge, it is not mandatory to do any surgical procedure, as we can provide the additional relief to the labial notch of the denture may be sufficient for the denture insertion and the procedure. In case of highly attached frenum, where relief of the labial notch would not be sufficient and can break the peripheral seal of the denture, surgical treatment is recommended at will, as if there is excessive or highly attached frenum, it will reduce the retention and stability of the denture. Now, correction of prominent buccal frenum. Usually they never present themselves large enough to warrant the surgical correction. If the buccal frenum is soft and hence it can easily be displaced by the denture without producing any injury. Removal of hypertrophic lingual frenum. Frenectomy is indicated for the cases of hypertrophic lingual frenum, which involves the removal of the frenum. In case of hypertrophic tongue tie, surgical management should be done. Tongue tie test should be done to determine the need for surgical requirement or correction. The patient is asked to touch his upper lip with his tongue. If the patient is unable to touch the upper lip with his tongue, then he or she is suffering from the hypertrophic tongue tie. If the lingual frenum produces displacement of the denture, then frenectomy should be done. Now it's removal of papillary hyperplasia. These are hyperplastic lesions which occur in localized area due to some form of irritation. So the papillary hyperplasia or hyperplastic lesions occur due to regular and long time irritation. The lesions may be either small or large, and if the lesion is small, it is treated by curettage. Large lesions are treated by split thickness supraperiosteal excision. Now next is treatment of Epilis fistulatum. It is a soft tissue reaction that appears in the sulcular region due to overextension of the denture phalanges. It is commonly seen in immediate denture cases where rapid ridge resorption occurs. So, Epilis fistulatum appears in the sulcular region as the denture given to the patient is overextended in the vestibular areas, as the denture has overextended phalanges. It is mainly seen in cases in which we give the patient immediate or a short term denture flange, as in that time ridge resorption occurs fast and the overextended dentures are formed. It does not require any special treatment. Shortening and smoothing of the denture is the better uh, option, and denture border will be sufficient. Once the tissues heals, the borders of the denture should be refined. Removal of ridge undercuts. Small undercuts which do not pose much difficulty in the insertion of prosthesis can be left untouched. Moderate single-sided undercuts also do not require any surgical treatment because the path of insertion of denture can be altered and parallel to the direction of the undercut, as it may also help in the increase in more denture intention. Severe undercuts or bilateral double-sided moderate undercuts require surgical corrections such as alveoloplasty and ridge augmentation. Now, management of prominent mylohyoid and internal oblique ridges. Internal oblique ridges and mylohyoid ridges are seen in the lingual surfaces of the mandible. Sometimes they become very prominent due to ridge resorption. They should be surgically reduced when there is repeated ulceration and loss of peripheral seal. Now, the reduction of maxillary tuberosity. A wide tuberosity is easier to reduce compared to the vertically large tuberosity. The maxillary sinus tends to expand into the tuberosity, hence radiological evaluation is compulsory and mandatory before surgical reduction. The interarch distance should be evaluated and the thickness of denture flange should also be reduced accordingly. Treatment of sharp spiny ridges. These ridges usually occur in the lower anterior region due to resorption of labial and lingual cortical plates. Ridge augmentation can be done. Usually, dentures with large flanges are constructed to avoid load on the crust of the ridge. Now, Mayer classified knife edge ridges into three types: sawtooth, razor like ridge with discrete spiny projection. So, the knife ridge is very sharp type of ridge which gives a sharp look and a fine, sharp, thin, spiky look. So, it is identified as a knife edge. All three we can examine by palpating the area of the ridge. All three ridges have a sensitive mucosal lining. Care should be taken to protect the mucosa. Now, tori. Tori is the bony enlargement or excessiveness of the bony part, excision of tori. These are small bony projections of unknown etiology which grow to their maximum size by the end of the third decade of life. Indications for removal of maxillary tori are interference of speech, loss of posterior palatal seal, poor dental stability. All mandibular tori should be excised because the mucosa of the tori is more prone to irritation due to constant movement of the denture during the mastication. Now, vestibuloplasty. It is the surgical procedure to increase the vestibular depth. It can be done using one of the following techniques: mucosal advancement, which involves the dissection and apical repositioning of the circular mucosa using a surgical stent. Secondary epithelialization. A full thickness flap is reflected, apically repositioned, and sutures with the periosteum at a lower level. The exposed area is allowed to heal by secondary intention. Now, epithelial graft vestibuloplasty. It is similar to secondary epithelialization except that a full thickness graft is placed over the exposed region, allowing it to heal by primary intention. So, in short, I want to say that vestibuloplasty a surgical procedure है जो that increase in the vestibular depth. Now, these are the three techniques which are of lead to vestibuloplasty. First is the mucosal advancement, in which we dissect and apically position the circular mucosa using a surgical stent so that we replace the circular mucosa more apically. Now, secondary epithelialization, in which the full thickness flap is taken out or reflected, and in this then we apically reposition the mucosa, and then we again suture with the then we suture that apically repositioned mucosa to the periosteum at lower level, so the exposed area is allowed to heal by secondary intention. Now, epithelial graft vestibuloplasty is a similar procedure of secondary epithelialization, but in this we use except that a full thickness graft is placed over the exposed region. In this we reflect the in secondary epithelialization we reflect the full thickness, but in epithelial graft vestibuloplasty the exposed region is covered by the full thickness graft as so that it will heal by the primary intention. Thank you. Please like, subscribe and share.